Well, good afternoon, everyone.
I'm going to introduce Cheryl Markham. Thank you for coming to the spotlight today. Focused on methadone expansion in Missouri and new ideas around methadone use. So I'm going to hand it over to Cheryl with DMH, and she's going to do a little intro.
I will do my thing. Good afternoon, everyone. My name is Cheryl Markham, and I work for the Department of Mental Health and Division of Behavioral Health in the state of Missouri. My role there is complex, but I'm here before you today as the State Opioid Treatment Authority, which essentially that person has oversight of all the opioid treatment programs in the state. So I have been in that role for 15 years now and have had the pleasure of working with every program in the state. We began with, I believe, 7 programs and now have 16. So we have created some access, but we are always looking for other ways to increase access for treatment services. So I'm here today to welcome you to the spotlight, which is access in Missouri, benefits, barriers, and big ideas regarding methadone. And with that, I will let Rachel take it away.
Hi, everyone. Thank you so much, Cheryl. We are grateful that you all have joined us today. I'm going to get started with some slides to walk us through some basics so that we're all on the same page before we head into our Q&A and get to hear from the panelists. Okay, bear with me here. All right, so using methadone as a recovery tool. Methadone is one of 3 FDA-approved medications for the treatment of opiate use disorder. Methadone itself is referred to as a long-acting opioid agonist that blocks the effects of other opioids and reduces cravings and withdrawal symptoms. So you can think of methadone as a bright light bulb that fits into a socket completely and satisfies cravings, satisfies sometimes that itch for those receptors to be filled. It's considered the gold standard in terms of treatment for reducing illicit drug use and risk of overdose among people who are on long-term methadone treatment. So you see here that we're not giving a long background in the state of the opioid crisis and how bad it is or how great methadone is. We're going to talk about that for a couple minutes, but we're just going to ask that you trust us on that, and we're going to get into more of the nitty gritty. I have 2 slides just showing some visuals of how effective methadone is long-term. Specifically, this graph that you're seeing here shows that methadone use over 5 years. Basically, the take home here is the longer you're on methadone, the less your illicit drug use. And you can see here, methadone and buprenorphine are very similar to each other on these lines below, compared to people who are on no treatment medications up here. So this both shows that the longer you're on it, the better, and medications, specifically methadone, are better than no medications at all. In this next slide, similar idea, but this is about mortality. This is about death, or on the flip side, survival. And so you'll see here, methadone is in the red line, similar type of thing, although this study went over 17 years. And this shows that the longer you're on methadone, the more likely you are to stay alive. And this is an incredibly powerful effect. Okay, so that's that on the effectiveness of methadone. Now, how do people get methadone? Through opioid treatment programs called OTPs. Now, only SAMHSA at the federal level can certify OTPs to dispense methadone. If you're getting methadone to treat opiate use disorder, you can't just pick it up at a pharmacy. You can't get it at your primary care office. You have to get it at a designated OTP. Now, OTPs within each state are overseen by an individual state opioid treatment authority. We already heard from our SOTA, that was Cheryl Markham at the top. And they are basically in charge of making sure everybody's doing what they're supposed to be doing, and also liaisoning with the federal government who oversees OTPs more broadly. Within OTPs, there are requirements, and we're going to talk about those, but specifically drug testing is a requirement on some level of frequency, depending on what stage you're at. And counseling is strongly recommended. Technically, it's not required at the federal level, but often in practice it is. There are also very strict take-home policies. And when we say take-home, it's very literal. Methadone comes in a liquid and it's in a little jar. And at the very beginning, you have to go to the clinic and take it basically every day in front of someone. And as you go along further in your treatment, you get take-homes, meaning you can take it home and dose at home. There are very strict policies around that. And another reminder to keep in mind is that there are federal regulations, but then state regulations can be stricter than the federal regulations if they want. And then at an individual agency or clinic, those regulations can be stricter than the state if they want. So the federal regulations are the bare minimum of what clinics and agencies have to do. Okay, now what do we mean by regulations and restrictions? First, and we're going to talk a lot about this today, but the stated goal of having all these rules in place is to prevent overdose, to prevent diversion of medication, meaning giving people meds who don't have a prescription, who aren't on methadone, it's not theirs, you're sharing your med, you're selling it, whatever, and just general misuse of methadone. Now, these rules are in place because methadone, like we said at the top, is a full opioid agonist. You could technically overdose on it. You could get high from it. You could misuse it. So people get really nervous about just having willy-nilly access to it, and the potential of diversion. So diversion control plans tend to include things like security, video surveillance. There's often security personnel at OTPs. In terms of administration, direct observation of ingestion is how things start, especially at the beginning of treatment. People have to physically watch you take it. And they also implement random callbacks to count your doses or ask you, hey, come in the next 24 hours for a random drug test. There's a lot of accountability with methadone treatment. And because of that accountability, there's very little diversion, although we'll be interested to hear from our panelists on their perspective on that today. Observed clinic dosing versus this idea of take-homes. Again, I'm not going to get into the weeds, but just remember that especially for the first 3 months and often for longer, you need to physically go to an OTP 6 days a week to get your dose. Often you get Sunday as a take-home, but 6 days a week is when you need to report to the clinic. And after that, you can reduce your in-person days by about 1 day a week every 90 days. So after 6 months, you would have to go to a clinic at the very least 3 times per week. And remember, clinics can impose stricter rules in the states or the feds. So when the COVID pandemic emerged in March of 2020, federal administrators loosened regulations around methadone to accommodate social distancing and safety protocols. So they said, these rules that we have on the books, you can follow them if you want, but right now you're allowed to give people up to 28 days of take-homes at a time, basically a month, if they're quote unquote stable. If they're less stable, and of course these are subjective terms, you can give them up to 2 weeks at a time. And this was a major game changer from the tight regulations that we were used to. And remember though, this is up to clinic discretion. In terms of telehealth, they allowed for telehealth for existing clients, but still for new clients, they needed to do in-person assessments. So quickly, I want to highlight 2 studies that have come out looking at the COVID-related policy changes and the impact that did and did not have on patients. So here's one study that came out from a large OTP system in the Bronx, and they reported the changes that they made, including stopping drug testing altogether. They used different metrics to assess patient progress towards their goals, and they drastically increased take-homes. Basically, about 47%, about half the clients had been attending up to 6 days a week prior, and that went down to like 1 in 10. And then most clients after COVID came once a week or less. The providers highlighted that the financial reimbursement was a problem with this because essentially they get paid every time someone comes. And when you reduce the amount of time that someone comes, you get paid less, and that this would need to be addressed if they wanted to sustain these changes. But importantly, in the first 3 months, they had no fatal overdoses, which had been a concern and a reason for caution for keeping that tight rein on methadone. So this was kind of an experiment, and they were like, hey, okay, well, at least we didn't have overdoses, and that's kind of the thing that we were worried about. This one was a qualitative study about OTPs in San Francisco, and they did in-depth interviews with both providers and patients. The take homes from this were that providers at this clinic moved more slowly and cautiously, at least it sounds like in the Bronx study. They increased really on a case-by-case basis, but they also reported no increase in adverse events among the patients for whom they loosened their restrictions. Patients who were granted more take homes really liked it. They valued it. They reported a better ability to attend to their daily priorities, jobs, school, childcare, et cetera. They had an improved sense of autonomy and honesty with their providers and feelings of transparency. And interestingly, they also reported taking their methadone more consistently and therefore reducing their other illicit drug use, because people said that to get to the clinic to get methadone had been a big barrier. And so often they didn't even get the methadone that they needed. But now that they were allowed to take it home, they took it more reliably. On the contrary, patients who weren't granted more take homes were really frustrated. They felt like the process was unfair, that it wasn't transparent how the clinic made their decisions, who got more take homes and who didn't, and they reported differential treatment. So these are some things to keep in mind and some things that we're going to ask our panelists about today. Also, the federal government has loosened restrictions on mobile units for methadone, and mobile units, mobile vans, whatever you want to call them, have been found to increase treatment retention and access, especially for underserved populations, either in rural settings or in high poverty urban settings. Now, in just a couple months ago in June, the DEA reauthorized the utilization of methadone vans, which had not been allowed since 2007. So this is a very recent change, and we'd like to ask our panelists today about their thoughts on incorporating mobile units in the future. So here in Missouri, historically, we have only had 3 state-funded OTPs in the entire state of Missouri. And when we say state-funded, we're talking about programs that serve the underserved, people who don't have any insurance or who have Medicaid, who are enrolled in MoHealthNet here in our state. Now, previously that was Center for Life Solutions and West End Clinic, who are both located here in St. Louis, and Rediscover, who's located in Kansas City. Now, there have been private OTP agencies through Behavioral Health Group and Colonial Management, but being private meant that people had to pay out of pocket. They were not state funded until this past fall of October 2020. Both BHG and Colonial, who are represented on today's call, became state contracted, meaning they could now serve the underserved population. So now we have 13 publicly funded OTP sites across Missouri, drastically increasing access to this life-saving medication. So I would now like to take this opportunity to introduce our panelists. So please come on camera when I say your name. We'll make a big show of it. First, I'd like to introduce Cheryl Gardine. She's the Executive Director of Center for Life Solutions. Please welcome Cheryl. Okay, I'm going to keep going. Next, we have Angela Manns. Hi, Cheryl. We'll kick it off to you all in a moment once I've introduced everyone. So Angela Manns is the VP of Wellness and Recovery at Rediscover in Kansas City. Welcome, Angela. We also have Dr. Lynn Taylor. Welcome, Dr. Taylor. She is the Clinical Director of the Opioid Addiction Treatment Program at the St. Louis VA, although has recently had a role transition, so maybe she'll tell us about that. Thank you so much for joining us. I'd now like to introduce Andreas Prince. Andreas, welcome to the webinar. He is a former OTP counselor and a person in recovery who has lived experience with methadone. So we are very grateful to have you here, Andreas. And similarly, Chris Corte, please correct me if I said your name wrong. Chris is a certified peer specialist and a person in recovery with lived experience with methadone. And last, we have Cheryl Markham, who you heard from at the top, and she is our state opioid treatment administrator with the Department of Mental Health. So welcome, everybody. I am going to stop sharing my screen so everyone can see your wonderful faces. Thank you so much. So now I'm going to, ask everyone to come on video and let's go around and please say your name again and say your role, on this webinar, kind of the perspective you're representing. And if you could kick us off by sharing what you think is the biggest misperception people have about methadone and opiate treatment programs that you would like to correct. And we'll take it from there. So let's start with Andreas.
All right. Hey, good afternoon, everybody. How you guys doing? So one of my biggest misperceptions about methadone is methadone and stigma, methadone and character. People seem to associate like poor character with methadone, which is a big issue because people prejudge people that use methadone. Also, too, I would like to see more access. You know, and if there was more access, I think it would be a substance to combat some of the things that impact addiction. So that would be my sort of beginning take on it. Beginning take, because some of the stuff that you were just saying, it was like, I don't know, you know. So,
Right.
but
Right.
I mean, from studies, I know some of that stuff is true, but at the same time, I think it's sort of a narrow perspective. So
Fair enough. We all come with our own perspectives. That's why we're all here today, to hear those.
and I say that only because I've been around methadone since 1991. My mom was a methadone user from the 50s, going into the 60s, going into the 70s. And so, you know, a lot of information has transpired since then to now. And I like to see more access to it. So,
Right.
yeah.
Thank you. And we're so happy you're here. And yes, disagreeing is wonderful. We welcome it. Okay, let's go to Cheryl Gardine.
Okay, you can hear me now, right?
Yep.
Okay, it took a few pushes of the button to get me unmuted. Hi, I'm Cheryl Gardine. I'm the Executive Director of Center for Life Solutions here in St. Louis, Missouri. I'm also the president of the Missouri Association for the Treatment of Opioid Dependence. And I'm also the Missouri delegate that serves on the National Board ATOD, American Association for the Treatment of Opioid Dependence. If I had one thing to say, it is the stigma around methadone. I hear a lot about people saying we're substituting one drug for another. And then the other big thing I hear when pre-COVID, we would go out and do presentations, and when I would be presenting and somebody would ask me, well, how long can they stay on methadone? And I said, however long they want. And I have patients that have been here over 25 years and have many gasps from the audience, like, oh my God, that's horrible. So them are the two things that stick out to me.
Wonderful. Thank you so much. Thank you for being here. Angela Mans.
Hi, I'm Angela Mans. I'm the Vice President of Wellness and Recovery at Rediscover. And I'm also one of our psychiatric nurse practitioners too. I would have to say that Andreas and Cheryl both stole my answers on misperceptions, but also I think that a lot of it is that they're going to make the neighborhood unsafe. You know, that you can't be within 500 feet of a school or a church or, you know, all of these other things that aren't accurate. So.
That's a good one. Okay, thank you, Angela. Dr. Taylor.
Hello, everyone. So when it comes to misperception, one, I second everything that folks have said in answering the question already. But one of the things is that for someone expressing a preference for methadone over some of the other modalities, that they just want to get high, right? That one really, you know, particularly when, you know, I've seen with my own eyes, they, you know, these other ones didn't work for them. So let's try, if we got three, let's let's try the third one, or let's go back to what they asked for in the first place before we, so that would be one. And then to the point about people staying on methadone, right? If you have diabetes, right, even if you get your diet under control and that sort of stuff, they're still going to want you to take your adherent, right? So people who have been on methadone consistently, right, and have been doing well, those people are treatment adherent. Why aren't we like celebrating the fact that these people are treating their long-term chronic disease and being adherent and attentive to keeping that, condition controlled? So.
Well said. Thank you. Okay, Chris, please introduce yourself a little bit more and tell us about the biggest misperception on your mind.
Hi, my name is Chris Cordy, or Cree. I go by that as well. And yes, I had a list of misconceptions and everyone has been said already. Dr. Taylor, to kind of piggyback off of what you said, I go into every single outreach, and when I tell them that I've been on methadone and how long I've been on it, I get a lot of looks like, and you're coming here to talk to me, but like I tell them, addiction is a disease, and people that have diabetes take medicine every day for their disease. People that have high blood pressure take medicine every day for their disease. And I just take medicine every day to control my disease. So that kind of like puts it in perspective when, like you said, when you look at it like that.
Right. And your A1Cs are under control, right? You've got,
yes.
Right.
Yes, I'm sitting in a house that I own with my children, driving a 21 vehicle and able to go on vacations. So yes, mine's under control, and I'm trying to help others get theirs under control.
Excellent. Thank you so much. Okay, let's close out with Cheryl Markham.
So yeah, everybody took the thunder, which is cool. There was one thing I would love to add though. Doctors assess and prescribe medications for the consumers. And when other people try to say that that person's dose is too high, they're not a physician. It is for no one else to say what a medication needs to be, because everyone has a different tolerance, a different way of metabolizing. There should be no capping of doses or anything like that. And I don't believe we have issues like that, but I've heard of them before. And that would be the other piece that I would add to this, that it is a big misconception that everyone should be on between 50 and 80 or 100 milligrams. That's inaccurate, it's inappropriate, and those that do not have the qualification should not be trying to testify to that. So that is my input.
Okay. Well put. Okay, thank you everyone so much for going around and starting with that softball. We're going to start now with some more in the weeds questions, and I'll just pose them. And this is really what today is about. We don't have slide presentations other than the one I gave. And so do your best to say whatever's on your mind about each question. Not everybody has to answer everyone, but if you have something to say, please get in there. After I ask the question, I'm going to go back on mute and not like call on people or anything like I just did. So have a conversation with each other. And when it feels like we've exhausted that question, we'll move on to the next one. Again, audience members, please ask your own questions in the Q&A. I'm going to keep an eye on those as well as the questions that we have logged previously. Okay, so let's get started with a very simple question. It sounds like a yes or no, but go ahead and expand on it, please. Should it be easier to access methadone? Why or why not? Take it away, panelists.
So I would be a yes, a straight up yes all day long. And the reason I say that is because people have their, again, preconceived ideals about what may happen if people have access to a medication. But I say medication because if you go to Walgreens, every medication is a controlled substance. So, this is yet another controlled substance. And yeah, people should have like way more access. It engages people if nothing else. It sort of sets the scene for what recovery could possibly be. And so I would say, yeah, more access, the more the better. You'll see harm reduction. You'll see just a lot of things change. And I'm glad of something that somebody said, which was dosages. You know, and I'm just throwing this out. Dosages are a big deal, and people want to regulate dosages, and you can't because everybody's different. So I want to see more access. That's me.
I agree with Andreas that I think it should be easier to get into methadone treatment, but I still think it should have the regulations and requirements that go along with it to keep both the, the consumer and the community safe. So. That's my answer.
I also agree that access would be one of the things we need, and I'm hoping that one day that we'll be able to do admissions via telehealth. They do it with Suboxone, but not methadone, and so I think that would help tremendously. And then, I think everybody, speaking for ATOD, I can say this, that across the United States, everybody has shortages of staff and trying to recruit staff and get them in there. And we have the same problem. So I agree that access needs to be, but I think that if we could do telehealth, that would improve it quite a bit.
I agree as well. I mean, if somebody wakes up sick and they open their front door to go take a 2-hour bus ride 6 days a week to a clinic, or they open their door and they see Pookie or Joe on the corner and it's right there, which one are you going to pick? If you don't feel good, which one would you pick? If you could go, to Walgreens, if you had a migraine and you could go a block away to a Walgreens, or you could drive, 35 minutes to a CVS, you're going to go to Walgreens.
So we apparently have a choir here, right? Because it is more access points. And Chris Cree, the scenario you draw is right on point. When Narcan first became available, I was like, Narcan should be as available as the dope, then we got to find a chance for people not to end up dead, right? And it's a similar sort of thing. If there's more accessible, so more points in more places, then people will be more likely to get the treatment. And as another, I think the technology at this point exists where someone could be in a, like you could have like a card, like a credit card, right? Like here you are, you're in your program, right? And then you could go, even if your home clinic where you came in was someplace else, you could go and swipe your card, right? So then you can get a dose. And then it says you got your dose for the day, right? Same thing with drops. I mean, I know there are many places where people are providing urine drug samples for other things, and things pop up on their phone. It says it's my time to go. They can go to any place, right? So the technology exists. Does the will or desire to utilize that technology for this group of patients exist? Right?
Okay, well, that's a good segue. I'm going now to the Q&A. You just said, does the will to serve these particular patients exist? From Anonymous, here's a question. Who do you see as being the most underserved population groups in your areas? What specifically do you think could be done to engage those groups?
I think that a lot of our homeless individuals are underserved because it's harder for them to get to where they need to go. I think that if we, the mobile methadone vans could be a great way to help get to the individuals that can't get to us. So, and then that way, you know, I mean, also, you know, providing the needle exchanges and things like that outside of, with those mobile methadone units, because, you know, that's also shown to encourage people to get into treatment. So I think those are the two great things.
Thank you, Angela. And sorry to interrupt. I just want to make sure that this attendee gets their questions answered. They did want to know too, what are you doing at your agency to reach and serve the underserved population? Are there any examples you could give from Rediscover?
Well, we have our community outreach case managers that will go and find people. Of course, we serve the underserved population. So, you know, we have 2 clinics located in very different areas of Kansas City. So we're, you know, we're pretty accessible. And then also we have several access points for buprenorphine as well. So all throughout. So.
At the VA, so when it comes to homeless, you know, the whole push to end veteran homelessness, there's lots of homeless services. And so for that, and for also re-entry and justice involved folks, part of the serving those communities is having some really close relationships with the folks who run those programs, right? And honestly and truthfully, providing some, you know, what would probably be called concierge access for folks, right? You have the relationships with the folks who work with homeless veterans, the relationship with the folks who work with justice involved veterans, so that they can they'll call up and say, I guess he just got out, right? You know, he doesn't want naltrexone, but he's clean. Can we get him, you know, in? And saying, okay, this is, you know, I know this person, if this person, you know, this worker, if they're saying this person needs it now, let's try and make it happen now, right? So it is having those relationships with folks who have relationships with people in those underserved, you know, populations or special populations.
I agree. So I do Epic right now, and those are like hospital outreaches mostly, and some in the community, and which is a great introduction to, you know, people gaining access that typically would not get access. And just from word of mouth, you know, when you're doing something effective, word of mouth is huge, huge, huge when it comes to communities, you know, and it's amazing how in this special population, that word of mouth is big. You know, it starts in a place and it just goes, it takes a life of its own. So, yeah. I wish everybody on this panel were like the regulators of methadone, because we all like like-minded, you know.
You got some people with some decision-making power on this screen.
Well, I would go with it, you know.
Okay.
I would definitely go with it. Yeah.
Well, let's segue then. Let's talk about what rules you would change. What do you view? We've talked a lot about like initial access, like those access points, but what about once you're in, how do you stay in? Can you all speak to what you think are the biggest barriers to long-term retention and engagement in methadone treatment? And if you had a magic wand, what regulations you would change?
Well, I would definitely change, and you'll hear me say it again, is to be able to admit via telehealth. And I think the first couple weeks of treatment are very important. We have a community support worker that does a needs assessment to see what their needs are, and will help them develop goals to get to where they need to be. The counselor makes contact with them in the first week, and we have 2 peer specialists on staff. They have been a godsend. The clients love them. So they get really involved in their treatment at the beginning too. So I think the more of us that you know, kind of put although we can't touch him, but put a warm hug on him and say, hey, we're here to help, and you know, please let us know what can we do for you.
I like to see more treatment slots, period. You know, the more, the better. Inner city and rural areas. You know, the rural areas are just getting hit hard with not having access. And the places that they have to come to may be an hour ride for some people, you know, and it's just hard, you know, when our Midwest winters hit, it's just hard. And then free access to medication, you know. People can't just afford to, you know, continue to try to pay for methadone, you know, where it's readily accessible, you know. And what I mean by that is that some of the paid clinics you could get in right away, other clinics you have to wait, you know. So yeah.
I have to second what you just said, Andreas, because as Dr. Winograd alluded to, I actually am not in St. Louis, I'm just literally 2 weeks ago, and came to New York City, where slots in the clinics are free, community, VA, whatever, right? And you should have seen my face. I was like, really? All of the clinics are free? Right? And they looked at me like, well, yeah, right? And I was like, all right then, right? And one of the sort of differences, and again, coming from a VA, from one VA to another, at the St. Louis VA, we had a fairly large census of methadone, whatever, because it was the difference between a paid slot or waiting for a state slot, or coming, getting a appointment fairly quickly and getting on board. And if you were eligible for VA care, it's free, right? Whereas here, and the census is a lot smaller because the choice, right? They can pick a place that's closer to them, and the whole cost thing is not a factor. So I can definitely, from like recent experience, say, yeah, it makes a difference.
Makes a difference, yeah.
Well, and I think if we could get some more medication units opened up that, that are part of my program, use my DEA, but we set up a medication unit, say in Farmington or wherever.
Yeah.
I think that would be very, very helpful.
Yes.
Cheryl, would you humor us and just explain a little bit more about what a medication unit is for those on the call who aren't familiar?
Of course. And I would like to also go back and kind of throw in my 2 cents about funding and slots and all of that, because that is something that I agree with everybody about and don't like it. So medication units are an extension of a home clinic. I always see them as like somebody would, buy an old Rally's or drive-through place, and it could be somewhere that maybe if you live in a rural area, but drive to the city for your dose every day, instead you could go to that place and get your dose maybe 6 days of the week and come to the clinic 1 day of the week. And that's just an example, so that it helps with transportation, saves on money. So that's a medication unit. It is brick and mortar. It does have a different DEA registration than the clinic, but it is connected to a particular clinic. The mobile units are also connected to a clinic, but they can have the same DEA registration as the clinic. Does that make sense? So, okay. And then to go back to the slots and the funding and all that, I just want to add that I feel so lucky because of October 2020, is that right? Yeah. As Rachel said, we were able to add, 11 clinics that are now eligible to take Medicaid in the state of Missouri. And of course, all of them can take Medicare. Also, we have SOR dollars funneling down from the federal government that are going into the clinics for people that either that have no form of insurance at all, no Medicaid, Medicare, private, anything like that. So I believe that more people have access and less people are worried about the cash they have to put out every day as a cash payment as a result of the 11 onboarded contracted programs that we have in the state now. Essentially, we have, well, 11, 12 now. We actually have 12 new ones. So every clinic in the state that's open now accepts Medicaid, Medicare, cash. Most of them accept insurance, I believe. I don't want to say that for sure, but I believe so. And then there are general revenue dollars for folks that have nothing, and SOR dollars for folks that have no form of insurance at all. So I think we are in a much better place than we were a year ago. You know, at this point, I would like to see more brick and mortars. I would like to see more medication units that are in rural areas. And I would like to see about 5 or 6 mobile units on the road, you know, coming out and going into the rural areas. But I think that's all I have to say about that. Rachel, did you want me to address anything else, or?
Well, no, that was good, but we have a question. I'm just going to keep taking
Go right ahead.
little natural segues. So
Sure.
Felicia Richards, hi Felicia, asked why, since you're speaking about mobile, her question is, why do mobile if the person has to come daily anyway? Why not just have brick and mortar? Would anyone like to speak to that?
I would. So the great thing about mobile is that it is like brick and mortar. So if a person, let's say the mobile unit goes to Schnucks every day between 2 and 3, and that person lives in the neighborhood, if they can't get to their home clinic, but they can get to the mobile unit every day to dose, that's considered daily dosing. Just because it didn't happen at the brick and mortar location doesn't mean that it wasn't under the supervision of a dosing nurse and probably a counselor, maybe a peer specialist if we're lucky, those kinds of things. Those mobile units are DEA approved as a pharmacy, but mobily, just like they would approve a brick and mortar. So it is, in a sense, daily dosing still. It's just at more convenience to the consumer.
I also want to add, in terms of mobile units, things about, 1, community, right? And 2, stigma, right? That mobile units are a very big opportunity for communities to basically see that, look, this is treatment. You know, they have minute clinics and CVS and all these sort of things, right? So to be able to present that in communities, and for people who are on methadone to be able to experience getting their treatment like they get other treatment, getting their medication like they get other medication, right? It's hard not to feel stigmatized when what you're doing is all segregated and you know, that sort of thing. So I think mobile units, particularly if they were, but on a lot of the drugstore, you know, of the, you know, it would, you know, it could do a lot for that whole thing about community and stigma.
I agree. When I first got on methadone, I was pregnant. I had fallen at work and broke my hip. So I was able to get on Medicaid. And back then, EMT was able to come pick us up and bring us to the clinic, which I lived in the north side, St. Louis Avenue and Whittier, and had to get to Hazelwood 6 days a week. So if I wasn't in that vehicle, I couldn't have gotten there, and I wouldn't be where I am today. So the fact of a vehicle being able to come to the neighborhood would be a game changer, in my opinion.
Excellent, thank you. So Dr. Taylor, you were talking about community. So speaking of community, what is the role and importance of the neighborhood setting that you're in, and the relationships with neighbors that you all have when working in or being a client of an OTP? Can you talk about the environmental context of where the OTP is and what that means?
Well, in a VA setting, right, we're kind of stuck.
Sure.
Right? But I can say that where, at John Cochran, it is in the city, we'll have veterans who will say, my dope man was across the street, right? So it's a trigger for me to, be in this area, right? And so again, with us, and we'll talk about it. We're like, let's acknowledge what this reality is, and let's talk about what it is that we can do. Is it that you feel like you need to go to a different, clinic, right? Do you feel like literally you're never going to make it? And they might say, well, really there's somebody to score with near every, because it's everywhere, right? That's not about it being near treatment facilities. That's about it being everywhere. But in terms of, other logistical things, my experience has been very much tethered to being at a VA facility. So others can speak probably, more informed about that.
Well, I know when we moved our clinic, we are in Hazelwood, and we've moved from another spot in Hazelwood. But when we were looking for buildings, we were looking in Florissant, which was very interesting. That we had a meeting with the mayor and his attorney, and I had some heavy hitters in the room, and they were asking, what do you do? And we explained to them. I think at some points the mayor fell asleep. He kept nodding out, and the lawyer just kept saying, the mayor don't have voting privileges. He only has veto power. And that's all he repeated the whole time. Prior to that, though, I had went down and met with the chief of police to talk to him about it, and he was very reluctant, but yet in his area, he had a hotel that was full of prostitution and drug use. And I was like, well, we could help with that. So it's that, again, that stigma that they see our clients as thieves and, rapists and murderers and all that, but yet you have a hotel up here that all these folks are, saying they're prostituting and drug use. So I think it still goes back to stigma and people who wants a methadone clinic in my backyard. I've heard that before.
I want to throw out too, just when you look at community, we have to sort of be like in the mindset of culture, cultural specific, because in some communities, some things work, and it's just a matter of figuring out what community actually works, because every shoe doesn't fit everything. I know in sort of the urban communities, services are different. Further out, services are different. So it sort of depends on the community, and it be cultural specific to communities, or culturally minded, shall I say,
Okay, here's another question from Anonymous. Different Anonymous. Well, I assume, I don't know. Okay, can you talk about the challenges you see people face in accessing recovery housing while taking methadone? So people who are on methadone, what are the struggles they face when trying to get into sober living or recovery housing?
I haven't dealt with it personally, but from dealing with past issues related to any certain medication use, sort of a big deal, but my deal was always to just look at it as medication and to look at it as whatever your facility utilizes for other medications, why not use the same procedure? The person is no different than the person taking insulin or whatever, so yeah. But I've heard that being a barrier for a lot of people. Yeah.
That's been one of the biggest barriers that we've had with getting people into recovery housing is that, they're still considered to be using when they're on methadone for treatment. So that's just always been a big issue. And then also another part of it is if they have several felonies from drug conventions, that will often prevent them from being allowed into housing like that.
I think it's the fact, a lot of the sober livings, like, you're on kind of, in-house, probationary period, to where you can't leave, sometimes, especially if you drop dirty when you first move in, unless you are with somebody in the house, or, somebody in the, like a coach or peer or something. So with Suboxone, you're able to go to the clinic and get a week or 2 weeks worth at your very first appointment. Methadone, you have to go every day. So you have to have somebody with you, to allow them for you to leave the house with some of them. So
Yeah, I've definitely witnessed folks have that problem, not so much because again, VA has lots of housing programs, but then when they go to sober living and recover, at the points where it's, quarter houses and that type of thing, which is exactly what Cree was saying. It's the rules of those housing organizations. And my experience has been, it's true. People will, I've seen people switch from methadone to buprenorphine, even if, methadone was, or people switch from sublingual buprenorphine to sublocade, to the injection, right? Because then they're like, look, I don't have any meds on me. I go and I get my meds, that sort of thing. But it limits people's choices, right? Then they're not able to pick what truly worked best for them clinically in terms of what's the specific thing we're treating, their substance use disorder. They have to, go to like, second choice, third choice in terms of what really they're trying to treat.
Okay, excellent. So I'd like to ask this question from Cynthia Weber from the Aviary Recovery Center. Are there studies or data to support or refute the claim that criminal activity is heightened within 500 feet of a methadone clinic? Thank you. Would anyone like to speak to that? We also have some studies pulled to answer that, to address the question specifically, but if anyone doesn't happen to have studies off the top of their mind and still wants to speak to it, please do.
I can't say, but I've never seen it, and this is something Cheryl could probably speak to, Cheryl Markham. So I worked in New Seasons, and a neighbor complained about a guy, and the person wasn't even affiliated with the clinic. He had a behavior going on, and I think he used the bathroom outside or whatever, but the guy was not affiliated with the clinic. So it just got lobbed, this behavior got lobbed into, being associated with people trying to get some help, so that was, you remember that, Cheryl?
Yes, I do. Yes,
Right?
I do. That turned into an investigation that I was on.
It did. It was something.
Yes.
But the person had nothing to do with the clinic, and it's crazy because, it's all these stigmas that come with a group of people. That's just not true. You're not saying that they don't do stuff wrong, but typically not true.
Right, but that's prototypical prejudice, right? That they were prejudged.
They were.
This person peeing in the corner has to be.
Well,
not to mention that it was a bar like next door. You know what I mean? So maybe it could have been like the guy from the bar.
I'd like to address the data. I don't have data, so I'm interested to hear what Rachel might have in her pocket to pull out here in a minute. But if you have it, Rachel, I don't mean to imply that you do. I'm sorry. But I am not aware of any data I would be surprised to hear if there was data saying that crime does increase. But those are just my thoughts on that. So I'm going to segue with that into seeing hopefully if we can find an answer.
Yes, sure. Thank you. And we are planning to put some links to these actual studies in the chat so you all can click around. We've been having an active chatter to try to find some of these studies off the top of hand. So thank you for asking this, Cynthia. And indeed, and this is consistent with my understanding of the literature and consistent with the anecdotes that we've heard so far, is there is not a positive association between the location of a methadone clinic and crime in that area. If anything, it has an effect of reducing place-based crime. So here's this study out of the Journal of Alcohol and Drugs from 2020 that found that violent crime specifically is what they assessed around drug treatment centers was much lower than around liquor stores or corner stores. And there was no significant difference between violent crime between methadone clinics and convenience stores. So they did comparisons across different settings, kind of getting to what Dr. Taylor was saying earlier about drug selling. It's not specific to the clinic, it's just specific to, it's everywhere. There was another study, this one was in the Journal of Experimental Criminology, and a little bit had both findings. It found that around OTPs, there was a decrease in property crime and total crime, but that there was an increase in drug and violent crime. So that contradicted the last study, but overall, there was a decrease in crime when they looked at all crimes combined. Now,
what year was that one?
2020.
Okay, so they're both around the same time.
Yeah. Now, I've been frantically trying to find the specific study that I know we've cited in a different presentation that compares methadone to other drug treatment interventions and looks at the outcome variable of crime, and found that methadone is the most effective at reducing criminal behavior and overall crime. So I would like to find that and put it in the chat before we leave today. So hopefully that answers your question. Cynthia, thank you for asking that. It sounds like this is one of those, on balance, better to have the methadone clinic around than not, even if there are some domains where you might see an uptick in some types of crime. Overall, it's a net positive and there's a decrease in crime. Okay, that's the crime question. Let's get on to some of these other ones in the Q&A. Here's one. People talked about long-term maintenance treatment a bit at the beginning. Anonymous asks, is the goal to be weaned off over time, or is the goal to continue treatment? They said, I would assume it is up to each client's specific goal. Could people talk a bit about short-term versus medium versus long-term treatment on methadone?
Well, here at Center for Life Solution, we leave it up to the client. I had a gentleman that I spent some time with him on the day of admission, and we sat down and talked about all the different medications there were, and he was scared on the methadone, he'd be addicted and blah, blah, blah. So we talked about, hey, you know, you can do methadone, we'll start you at a dose, get you at a dose that you're stabilized at, and then start a slow titration. And that's what he's doing. So he came in with the mindset that he was want to get stabilized, detox down, and be done. Now there's others that, like I said, I've had here over 25 years, they're on very low dosages and they don't want to quit. And so there's no reason for us to make them quit. They're doing very well. They have jobs, they have houses, they have marriage, they have children. And so we leave it up to the individual on what their plans are and how they're doing.
So when I first got into the process, I was a short-term methadone user. And for me, it was effective because of just the lifestyle that I, lived. And so I just didn't want long-term anything, long-term drug usage, long-term methadone usage, long-term anything because of just my lifestyle. But it is solely based on individuals. And we have to sort of reinforce the fact that, you know, it's an individual choice, it's an individual's journey, you know, and broaden the perspective on looking at the impact of the disease. Are you a type 1 diabetic? Are you a type 2? You know, just from that perspective of disease. And so to really reiterate that, it's just an individual pathway to one's own personal recovery.
I personally have been on it, oh, Cheryl, what, 13 years, going on 14 years. I was pregnant with my son, he'll be 13 next month. So, and I had to do my physical the other day, and the doctor asked me if I had thought of getting off of it. But I have metal throughout my whole left leg. So I also use it for pain management. And I told him, no, I don't want to get back on pain pills, because that's one of the times that I did have some clean time. And, you know, I hurt my leg again and had to get back on the pain pills, and it started the whole thing all over again. So, you know, I feel like it helps with pain as well as, you know, sobriety and your typical MAT.
I agree again with what folks are saying. Some of the things that I've seen, you know, with people who stay a long time, there are folks who, like, literally they've tapered down to 5 milligrams, right? And they take 5 milligrams of methadone, and we know that that's not, you know, I can take 5 milligrams of methadone, it's not gonna, you know, it's not gonna do anything. And when we'll ask, it is more the sense of for that veteran and his recovery, right? For his management of his condition, right? Here's what's working for him, right? And it used to be that we had, you know, because he's on 28 days, right? Because it's like, really, what, you know? And, you know, there was a point where they'd ask every 20, you know, you ready to go down, you know, and come off? And he finally said, it's like, you guys trying to get rid of me, right? And so we're like, okay, you know, you can tell us whenever you want to do that. Otherwise, we're going to it ain't broke, right?
If it ain't broke, why fix it?
Okay, seem to be some pretty unanimous consensus around that one. So let's move on. I'm hoping to get to some ones where there's some disagreement. Let's have a little spiciness. Okay, so let's talk about how you all handle people who continue to use illicit substances or cannabis, even if it's legal, or something other than methadone. How do you address that in your clinic? What are the pros and cons? What are some of the nuances? Like, what goes on there? Can you speak to how you handle it with those clients?
Can we talk about the weed, right? Because, oh my goodness, it was an evolution. Because, you know, initially it was like, well, you know, a positive is a positive, you know, on your UDS, that sort of thing. And what it was as of 2 weeks ago, right, was that folks who were going to continually use marijuana, right, if they, you know, their max was half of whatever the true maximum was, right? So if the max is 28 days, right, the ceiling is put at 2 weeks, right? And there are people who I have seen, you know, who I saw over the years who were consuming cannabis regularly, and they were like, you know, 2 weeks is fine, right? And then when they decided they wanted to be able to go to 28 days, right, they'd stop the weed, right? So I'm conflicted even within myself, right, about having a different policy for people who smoke weed or ingest cannabis versus, you know, people who don't, or versus, you know, other substances. There's some clear safety reasons, right? You know, talking about cocaine, talking about alcohol, right? And dispensing medications and that sort of thing. With cannabis, you know, it's all sort of, one's stance. So there's the conflict right within me.
I'm a advocate for take weed off the table. Like we're in a different day and age where it's legal in some places, blah, 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 blah. Take weed off the table. Let's just do that, because that's something different. But looking at overall substances, with a person continuing to use, that's part of the treatment process, and so to look at it in a very wide perspective, you have to sort of have this perspective of understanding use and the person, and is there any reduction in use? Because if there's a small reduction in use, clinically they're making some kind of a gain. It may not be the gain that I want or the gain that you expect, but any reduction in use is a big deal, and so that's sort of my take on it, to widen the perspective on use so that you can understand or motivate the person to understand change and to understand the impact of continued use, and to actually use the MAT medications to reduce use, so I think it's a clinician thing, not a patient thing. So.
I remember back in the day, when Michael Coute was the director at DMH, and we didn't test for marijuana. And then about 15 years ago, they had to start testing, and 76% came back positive. So I kind of wish we could go back to that not being mandatory.
I agree. The one thing that popped into my head also, though, with not so much about, and in this case, it would be smoking, but with like primos, right? We had folks who were very stable, in their treatment off opioids, right? So they're in recovery, that kind of stuff. Smoke cannabis, right? They'd come in and we would see like they pop positive for fentanyl, because if they weren't growing it themselves, right? Getting, weed that was tainted with things, right? And I know one of the ways that at first that happening out in the community came to our attention was somebody, well, we know this person is not knowingly using opioids, right? Because then when we presented it to them and, that sort of thing. So that's just one thing about like this one more sort of window through which, things can blow, no pun intended, that I have seen, occur. And that's not about people, that's not really about people in a substance use disorder. That's about coming in contact with it, unbeknownst.
Angela, I've been seeing you trying to get in there. Go for it.
Well, I was just, when somebody's using a different substance, it's kind of figuring out why are they using that other substance? What barriers do they have to abstinence, or, is it something that's with their mental health, or, there's so many things that can cause or lead to other substance use, that it isn't just necessarily they're using something else, it's why. And almost always there's a why.
I know a couple of our patients who have the medical marijuana card prescription. One of the ladies is battling cancer, and she's been using it for appetite, and she's actually, the cancer is going well. It disappeared from her breast, and she still has a few little spots. And then one guy that comes to mind real easily is that he takes benzodiazepines for anxiety disorder. And if I know him very well personally, many years, if something doesn't go his way, he will blow your phone up 20 times a day. And it's like, for him, he chose to continue on benzos and not do the medical marijuana. But I could see a person like that. And then we had another guy that was kind of similar, that had paranoid schizophrenia, and he was smoking weed, and he was calm. And when he came into the clinic, he was calm and relaxed, but you could tell when he didn't, that he would pace the lobby and different things. So personally, I see some good in it for patients. That's just my personal opinion. That's not Center for Life's opinion or AZA's opinion. That's just my personal.
Well, I think you have to look at the evolution of change. You know what I mean? Like, we were against substances, no substances, you're not in recovery. But the evolutions, we have to change with the times, and be willing to put your neck on the chopping block to say, well, okay, it's weed, you know what I mean? And so, yeah, we have to be willing to change. We can't just be in this little box and think we do people a disservice by doing that.
One thing, we had a client that had medicinal marijuana, and we actually, we didn't know if we could give him takes or anything, and we wanted to make sure we were following the rules. So we actually submitted an exception, and SAMHSA came back with, as long as the use of that marijuana is in their treatment plan and how that helps them, that it's okay and they can have take homes. And so, I think that there's a changing even at the federal level on that.
One of the things I looked at when I start seeing like more people using marijuana, like an increase in it, was to make sure that it wasn't interfering with clinical use of, do you now have a diagnosis for, marijuana dependence? So then I had to structure a conversation around, I should know you smoke weed. I should not know that you smoke weed. I should know that you drink, because if it's interfering with your daily routines where I can identify your marijuana use, then that may be problematic, but what you do at home behind closed doors in the safety of is a whole different conversation, so I think at this point in time, we can start having those conversations around what's acceptable in terms of use and then be able to incorporate that in a treatment plan or a conversation. So
I have to make a comment. So I just want to go to something very, very basic. It is not unusual for a consumer to come in with a diagnosis of opioid use disorder and marijuana use disorder. And when it comes to harm reduction, if someone is able to stabilize on a dose of methadone or Suboxone or whatever it may be, and is no longer using opioids, that's harm reduction. That use of opioids may kill them. That use of marijuana, probably not. There's probably not going to be an overdose. You probably shouldn't drive. You may not even want to walk. I don't know. But harm reduction is something that we have to look at. And if that is taking away the possibility that someone is going to accidentally put fentanyl into their arm, that is what we should be looking at. And that's my opinion.
I'm gonna pounce on that. Thank you for bringing up the term harm reduction. That's a great segue to a question in our Q&A from Miles Hoffman. So this is a two-parter here. So first, let's ask the harm reduction one. What methods of harm reduction, besides giving active users naloxone, so thinking bigger here, do you all advocate for with clients who continue using? Can people speak to that? And then I'm going to try to ask a second part.
I think anything that you can give people to reduce harm, if they're still injecting clean needles and, and kits and all that kind of stuff, if they're still working, making sure that you have condoms and everything else. It's just whatever you can get or use to help them stay safe is harm reduction. So may not necessarily be the most popular idea, but we're about saving our.
Here's the question, not to speak for Miles here, but at your opioid treatment programs, do you all openly talk about that with clients? Can they come to you and say, I'm still injecting blah, 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 or maybe it's caught in their drug testing, urine drug test, whatever. Do you provide that safe use education? Do you talk to people about injecting strategies or where to get syringes or testing their drugs or things like that? Or is that kind of like out of bounds?
We do.
We do.
We do. Yeah. I think one of them, go ahead.
Well, I was gonna say that with the relationships that you have with most of your clients, they're pretty honest about use, and so developing strategies around harm reduction and reducing use and getting to a place that they want to get to, it's an honest conversation about what can change, what stimulates change, so on and so forth, what may be stressors. I heard Angela talk about that. There's always a why, so if you're not having those conversations, that may be a problem.
Right. Yes. Again, there's a choir here. I got the robe on while because you say, what are some of the things that we do? It would be time and communication, right? That's it. That's a harm reduction strategy. It's like, hey, your last 3 urine drugs, usually it's like if you get one bias, okay, right? But the second one, it's to talk about it. It's like, look, these last 2 have been, what's going on, right? Or if they're new, right, say, we're going to look for these numbers to reduce, and then to say, tell us, how much are you using now, right? I use 3 times a day. I use when I get up in the morning, that kind of thing. Can you, which of those can go first, right? Because is your goal to get to where you're not using anything except what, your medication that's prescribed? And they'll say yes, right? Because why else would they have come to a treatment clinic? And then to say, okay, if this is the goal, here is the time, here's the time frame we're talking about. If it's 3 times a day, we're trying to get you down to where it's 0 times a day, right? Or we say we're going to try and drop 1 a week and, titrate a dose, that sort of thing. So it is, Andreas is, it's having the conversation, right? Because particularly if you're using urine drug screen results, and you're talking about fentanyl and it, the street fentanyl, it hangs around, right? So from the point where they say they stopped using, right, you got to go like 2 weeks off sometimes for them to get to 0 anyway, right? And so it is time and talking.
I think another big part of that too is not only having the conversation with the clinician, but having it at every single stop in that clinic. So the dosing nurse talks about it with them and, hey, do we need to talk to the doctor about getting your dose changed? And this is when we kind of want to see, your use decrease, and just providing all of that education and support. And, sometimes bugging them quite a bit, but they get used to it. They end up loving it. So, but it's just everybody having the ability to have that conversation and the same conversation.
Right. It's like collaborative accountability as a harm reduction strategy.
Yes. Mm-hmm. And I think in that conversation, we also need to identify some of the weaknesses in that chain, because everybody can't do everything. Like some people would be like, that's dumb nurse told me about my use. I don't mind you telling me, but they shouldn't tell me. And I'm like, hey, hold on. We're all on, we're all a team and we're all concerned, So, we have to kind of look at the chain, the process sometimes, and see who can sort of, how we can work together to achieve the outcomes that best serve the patients, the clients. Yeah.
Well, if the clients say that dumb dosing nurse, what's the dosing nurse not getting at with them? Because honestly, they should be very, very close to that dosing nurse because they see them every single day. And so that's a big thing. If there is a problem with one employee, you have to figure out why and address it, and either educate the employee or do whatever you have to do to make the patients feel safe with every single person they encounter at the clinic.
And I agree, but, one of the things that I've observed is that some people have different skill sets. you know, within a clinic, within a certain setting. And me, you, and three other people on here could say the same thing to the patient, and the patient might get offended by how the first person said it or the fourth person said it. And I'm like, what's the problem for real? You know, why? Why are you having a problem with this? And so, you know, just looking at as a team how we can collaborate, which I think is big in staffing the process, people's processes. You have to have that staffing so that we're all on the same page and that the patient know that we all have this, we all want a positive outcome for it, you know, so, yeah.
It's true, because if all the, you know, in the VA clinic, there's a counselor, a nurse, a physician, you know, at minimum, right? And then sometimes like a, you know, therapist, psychologist, you know, whatever. And they'll circle up and they'll say, everybody asked about those UDS results, right? And you can piece together a much fuller picture based on, this is what they said to the nurse, this is what they said to the physician, this is what they said to the counselor. All of what the you know, and this is all of what the veteran's saying was true. It's not like they were lying to anyone. It's just the different roles and the different relationships that that individual, in this case veteran, had with these different people, meant that they talked about different things when it came to the use, right? And as a staff, as a team, you got to come together and say, let's put this all together, right? And see not just the information, but okay, why were they telling this to the nurse, right? Is it based on the relationship with that person? Oh, they go way back, you know, and they're the one that they always come to. Or is it that a nurse should, you know this in the veteran's mind, and that type of thing. So Andreas's point is well taken.
Well,
I'm sort of one, excuse me, Rach, I'm sort of one that says, I mean, you know, the UDS, the drop screen comes back, okay, cool. We know it's definitive in some respects as to what it is, but the conversation around use comes way before a tox screen comes back. You know what I mean? So that we're all on the same page. And I'm saying to the staff, look, we need to look at this or look at that as it pertains to the patient, because, you know, they may miss a tox screen. You know, they may intentionally miss a tox screen, which, you know, they do all the time, but there has to be a conversation around use, not just based on one thing, you know. Because some people see that as just the end all do all, and it's not, you know, it's the relationship that you have that sort of suggests what's going on in between, you know, so that you can even look at reduction in use, so, yeah.
So this has been an incredibly fruitful conversation. We have 5 minutes left. So this flew by. I am so sorry that we have not gotten to all of the questions in the Q&A, and I'm embarrassed that we haven't really even talked about the COVID related regulatory changes. We had so many plans, but anyway, let's end it this way. Let's spend the last 5 minutes, if we could go around and have all of our panelists give a closing remark or two. And as you do that, let's answer Karen King's question that she just put in here, which is, what can we do to make treatment less punitive? So specifically, I'm going to ask that you, when you answer this, think about something that your clinic isn't doing right now, but you think they should. And if you're not affiliated with a clinic, then, you know, do the one that's closest of mind. Not something that you're already doing that you want to brag about. Say something that you want to push it a little bit further and that you think this would make an impact and make things less punitive in your clinic. Okay, so let's just go around. We have 4 minutes left. So if everybody could make sure to cap it at 30 to 45 seconds, what would you do to make things less punitive at your clinic?
Personally, I would just be more open to what patients, I would lean more toward what patients feel is a positive outcome for them. If something was, you know, on the table for a punitive reality, what do you, you know, defer back to the patient to say, what do you think? would best address this situation, you know, so that there's more accountability coming from the person, which may be more effective in longer term outcomes or addressing behaviors and ideas and attitudes about clinic and about institutions and about input. I'm done.
I would say, and this may be kind of pie in the sky, but to have, particularly for patients who've, you know, been on the program and have, you know, sort of established things, for them to have a like a get out of jail free card for particularly in an instance where they didn't let their urine speak for them, that they spoke up and said, look, I messed up, right? So, you know, and to have that, I know years ago, my bank sent me this thing and said, oh yeah, you got one, you know, oops, mistake, so that like if you overdrew, they wouldn't charge you that $35, you could turn in that sort of thing, right? And so to have something like that, and to have it where like when that person has had a relationship with the clinic, they've done well. So here, you've got this, you know, sort of room, you know, to make an error, you know, nothing, you know, grievous, right, kind of thing. But you made an error and it's like, it's okay, you earned this, now you cash this in and you go
Okay.
forward.
Creative idea. Thank you.
I think having the conversation without having a direct, which is pretty much the same thing that Dr. Taylor was saying, is you have the conversation, but you don't necessarily have a punitive action that goes with it. You know, now after you've the same action, you know, numerous times, you know, you start talking about things, but, you know, like that first time is, you know, you could talk about what happened, but not have something else happen, not reaction, just discussion.
No actual tangible consequence. Great, Angela. Let's end with Cheryl Gardine to bring us home.
Well, it's kind of the same as what others were talking about, is having a conversation with the client and saying, what can we do to help you? What's going on in your life? What can we help you? What do you need to work on? You know, and maybe it's to increase their counseling, you know, maybe have them come in more often or telephonic phone with their counselor and with the peer specialist. We tie them in a lot. But the peers, the clients listen to the peers. So that's kind of where we're at, where we have a sit down conversation with them and do not say, okay, you're being administratively withdrawn, but we're saying, hey, we need to update your treatment plan. What are the goals you want to work on? What do you think we can do to help you?
Right, that's a nice spirit to end on. So I want to thank you all so much for giving us this time on your Friday afternoon and your wealth of experience and expertise. To all our attendees, I know we've lost a few since the 2 o'clock hour, and now people have to get to where they got to get to. Thank you for attending. Thank you to the addiction science team who behind the scenes set this up. Katie Brown, Brittany Blanchard, Erin Ruiz, Bridget Coffey, Alex Duello, we appreciate you. And thank you all so much for coming today, and we'll send out emails with a bunch of stuff in them about this. So take care, have a good weekend, and we'll see you next time.
Thank you.